Actually, Dr. Fady Haddad from Lebanon, he is not present now, so we'll present a recorded video for him regarding the mid-aortic syndrome in a child.
Good morning, everyone, and it's a privilege for me to be in this fantastic meeting. And I thank the organizer committee and the PAVIS for allowing me the privilege of sharing this presentation with you. I wish it would have been in person. Unfortunately, for situations we're all aware of, I'm going to have to uh, share it online. I'm going to discuss with you mid-aortic syndrome with the case presentation and discuss the management. Mid-aortic syndrome is a rare clinical condition in the pediatric population, often present as severe hypertension, and can result in life-threatening complications. A triad of hypertension, diminished pulses, and abdominal bruit is typically described. However, often the patient presents with hypertension-related complications. This is a 6-year-old boy, healthy and athletic otherwise. 2 weeks earlier had presented with a sudden onset left hemiparesis associated with dysarthria to another institution. Computed tomography of brain revealed an intracranial hemorrhage in the corona radiata in the right hemisphere. Incidentally discovered severe hypertension up to 200. The boy was referred to us neurologically almost completely recovered. His blood pressure was 135/85 for his age group, which is stage 2 hypertension, on 4 antihypertensive medication well optimized. His blood pressure in the lower extremities was about 65/40, and all pulses, including femoral, were non-palpable. On your right-hand side, you can see the severe critical coarctation in the distal descending thoracic aorta and above the celiac artery. We have previously published our experience in multidisciplinary management of aortic coarctation requiring stenting in cardiovascular revascularization medicine a couple of years back. The setup was there for us, and as any similar coarctation, we put this case for a discussion in the multidisciplinary group, including vascular surgery, pediatric cardiology, pediatric cardiac surgery, and even we discussed it in the multidisciplinary conjoint decision with our group, with our friend, probably in the audience here, Murad Salam from St. Thomas. And after extensive discussion, we reached the decision that the best thing for that child, and considering the anatomy, is to attempt an angioplasty cautiously, and if it works, we can bridge for him the intervention or the final procedure for later during his adolescence. Patient was brought to the angio suite, a 5 French sheet originally placed in the femoral artery. We crossed without too much difficulty originally with a 014 wire, the coarctation, and we placed a pigtail into the descending proximal to the coarctation, and an angio was done showing the following: extensive collateral intercostal as expected and the site of the coarctation, and the patent celiac and mesenteric and renal vessel below. At that point in time, we decided to test with a small balloon dilatation to check the compliance, and the pre-dilatation 6 mm by 3 cm balloon was used, and there was a good response and forming of the balloon with that, but expectedly there was a recoil of the stenosis. At that point, we decided to proceed. So the sheet was changed for a 7 French long sheet. And as you may notice, after the long sheet was crossed, the stenosis, there was complete obliteration of the lumen only from the sheet, and the distal aorta could not be visualized. Decision was made to proceed with a covered stent that was 9 mm by 37 mm, inflated to 12 atmosphere. A residual area of stent aortic coarctation was noted after expanding the stent. And with that in mind, decision was made to redilate with a higher pressure balloon that small residual area in the middle of the lesion. For that purpose, a 7 by 2 millimeter balloon was used, inflated to about 18 atmosphere. And following completion, a pressure gradient was reassessed with pullback maneuver. This is the image of the stent after final expansion. The image doesn't project very well. we look at the completion angiogram, but there is really minimal residual narrowing or waste inside the stent. This is the completion angiography, showing really, at least initially, an excellent angiographic result. We're very satisfied with that, with the presence, of course, of the poststenotic dilatation at this point is still there. The child had immediate palpable pulses post-op. His ABIs improved significantly after the procedure, were 0.8 on both sides. However, this is his 6 months follow-up, and he is off antihypertensive drug completely. His blood pressure is 105/55, and his ABIs are 0.9. And he now is back to full, complete athletic activities and schooling. Mid-aortic syndrome is a variant of classically described aortic coarctation, which account for 5 to 8% of all congenital heart defect. Mid-aortic syndrome accounts to 0.5 to 2% of all cases of congenital aortic narrowing. Most cases of mid-aortic syndrome occur in the suprarenal segment of the abdominal aorta, representing 29 to 60% of all mid-aortic syndrome cases. The prognosis is poor if not detected, and very dismal if not managed early, with a reported mortality rate approaching 50% by the 4th decade of life. There are 3 facets in the management of mid-aortic syndrome, including medical, endovascular, and surgical. Medical interventions designed to control the patient hypertension and thus avoid hypertension-related complication. However, medical intervention alone is insufficient in most severe cases to control the hypertension and its complications. Surgical interventions include aorto-aortic bypass, thoracoabdominal bypass, reconstruction, patch graft, and aortic patch placement. Again, however, in the pediatric population, they represent a unique challenge when it comes to aortic reconstruction. In particularly, the implantation of synthetic graft material in a growing child is associated with several complications on the long run, including the graft itself becoming a coarctation because of the size mismatch when the child grows, development of pseudoaneurysms, infection, etc., requiring more often than not re-intervention at an older age. Novel surgical procedure like the MAGIC procedure using the mesenteric artery growth, or the Tesla procedure using tissue expander to elongate the aorta and then redo an end-to-end anastomosis may have a role in putting back early procedure in the picture or on the spotlight. Both procedures were developed at the Boston Children's Hospital in 2018, and 2.5-year results are encouraging. However, we still lack long-term outcome from those early surgical procedures. The endovascular management, however, are a more recent addition to the therapeutic options for mid-aortic syndrome and involve, with or without stenting of the narrowed segment of the aorta, dilatation of this severely tight coarctation and improving the distal and renal perfusion. A systematic review and meta-analysis published in 2023 in the European Journal of Vascular and Vascular Surgery reported that endovascular therapy was associated with higher complication rate and inferior control of hypertension compared to surgery in the pediatric population, at the cost on the long run, of course, with for the surgical counterpart with higher reintervention and other major operations. Interestingly, they reported the inverse findings in the adult population, whereby surgery achieving inferior hypertension resolution when compared to endovascular therapy. So probably we're going to see more and more long-term outcomes in the endovascular procedure still. In conclusion, mid-aortic syndrome is a rare condition in the young, unrecognized, and untreated can lead to serious life-threatening complications. Treatment of hypertension is mandatory but often not enough. Surgical aortic procedures are plagued with redo and reoperations and long-term complications. Innovative surgeries may be promising. Balloon angioplasty and stenting may palliate the hypertension and serve as a bridge to definitive aortic reconstruction at a later stage when the child has completed their growth, thus avoiding multiple open major surgical procedures on the kid. Thank you and enjoy the meeting.